This is Jose Pacheco. I'm an assistant professor in thoracic oncology and developmental therapeutics at the University of Colorado Cancer Center. Today, I'm going to give a short summary of some of the important abstracts in non-small cell lung cancer that were presented at this past virtual ASCO 2021. One of the highlights was a targeted therapy for KRAS G12C mutated non-small cell lung cancer. This targeted therapy is called sotorasib, and it's an oral agent that was recently FDA approved for use in KRAS G12C mutated non-small cell lung cancer. This oral agent showed an objective response rate of about 37% in patients who had a median of 2 prior lines of therapy, a progression-free survival of 7 months, and a median overall survival of just over a year, which is much better than what we'd expect to see with standard chemotherapy options for these patients like gemcitabine or docetaxel. Another important abstract in this past meeting was an antibody-drug conjugate called Patritumab Deruxtecan. This antibody-drug conjugate was evaluated in EGFR mutated non-small cell lung cancer patients who had received prior EGFR inhibitors and prior platinum-based chemotherapy. This antibody-drug conjugate in this patient population demonstrated an objective response rate of 39% and a median progression-free survival of 8.2 months. And these were patients who had a median of 4 prior lines of therapy. So these efficacy outcomes were much better than what we would expect to see with standard options for such patients like gemcitabine or docetaxel. Similarly, for patients with EGFR exon 20 insertion mutations, there is a new drug called DZD9008 that had results presented this past ASCO. It is an oral agent, and the objective response rate in this study was approximately 40%, which is better than what we'd expect to see with similar agents with chemotherapeutic agents like docetaxel or gemcitabine. The objective response rate is similar to what we would expect to see with the FDA-approved agent Amivantamab for this population with EGFR exon 20 insertion mutations. However, this drug is oral as opposed to intravenously administered like Amivantamab. In small cell lung cancer, there was a bispecific T-cell engager, Tarla Tamab, which recently had data presented this past ASCO. It did demonstrate at the higher doses response rates ranging from about 20 to 30% in long durations of response. With this drug, there was a fair amount of cytokine release syndrome, but it was mostly low grade and easily manageable. There was also an update on the Checkmate 9LA study presented at this past ASCO 2021. And it was seen that with a 2-year follow-up that there was maintained significance of both median overall survival and 2-year overall survival with Nivo plus Ipi plus chemo compared to chemo alone. And the PFS benefit was similarly maintained with additional follow-up up to 2 years. There was another study presented this past ASCO 2021 by Dr. Mark Sosinski, and it looked at 3 different clinical trials involving atezolizumab and chemotherapy versus chemotherapy-based regimens alone. And it was observed that in both patients who had chemotherapy or chemoimmunotherapy, that those who had low-grade immune-mediated adverse events had better overall survival than those who did not, or than those who had high-grade immune-mediated adverse events. There was also the Crystallus phase 1 study that was presented at ASCO 2021. It suggested that the combination of Amivantamab, which is an IV-administered agent, and Lazertinib, which is an EGFR tyrosine kinase inhibitor, may have efficacy in patients who have progressed on prior osimertinib. There were some biomarker studies suggesting that in patients who have IHC high expression of EGFR or MET, that this combination may be particularly effective with objective response rate of 90% and PFS of over 12 months. But this was a small subset of 10 patients where this was shown. This particular combination does appear to be effective, but we need to see more data and better develop biomarkers to predict who these patients are that benefit from this combination. So in summary, there were several new therapeutic options presented this past ASCO 2021. It appears that there are new options emerging for patients with EGFR mutations who progress on osimertinib. There is a new oral option that may be coming down the pipeline for patients with EGFR exon 20 insertion mutations. And we're seeing remarkable efficacy of a new oral inhibitor for KRAS G12C mutations. Thank you for your attention. 1, 2, 3. Hello, this is Jose Pacheco. I'm an assistant professor in thoracic oncology and developmental therapeutics at the University of Colorado Cancer Center. Today, I'll be giving a short summary on some of the highlights from lung cancer at this past ASCO 2021. One of the highlights of this past meeting was an oral drug that was recently FDA approved for patients with KRAS G12C mutated non-small cell lung cancer. This oral agent is called sotorasib, and it was evaluated in a phase 2 study called the CodeBreak 100 trial, demonstrating an objective response rate of 37%, a progression-free survival of about 7 months, and an overall survival of just over a year. And these were patients who had a median of 2 prior therapies. This is encouraging data and suggests this is a potential option for patients who are previously treated with KRAS G12C mutations. And it does appear to be better efficacy data than what we expect to see with docetaxel or gemcitabine. Another highlight of this past meeting was an antibody drug conjugate called Patritumab Deruxtecan, which was evaluated in patients with EGFR mutated non-small cell lung cancer. These patients had a median of 4 prior therapies, and they had received platinum-based chemo and EGFR tyrosine kinase inhibitors previously. In this patient population at the recommended phase 2 dose, Patritumab Deruxtecan demonstrated an objective response rate of about 40% and a PFS of approximately 8 months. So again, this was much better than what we expect to see with docetaxel or gemcitabine-based treatments. Also, for patients with EGFR exon 20 insertion mutations, recently there has been an FDA approval of an intravenously administered agent, Amivantamab, which demonstrated objective response rates of 40% and PFS of 8 months. But that is the only agent approved for that population, specifically for patients with that EGFR exon 20 insertion mutations. However, at this past meeting, there was a new option that was presented. It's an oral drug, DZD9008. It demonstrated similar objective response rates of 40% when compared to Amivantamab. And it does appear to be an option that may be potentially efficacious and potentially available in the future for this particular patient population. For small cell lung cancer, there's a bispecific T-cell engager, Tarlatamab, which had data presented this past ASCO. This is a bispecific T-cell engager targeting CD3 on T cells and DLL3 on small cell lung cancer cells. At the higher doses, objective response rates were seen in about 20 to 30% of patients, and these responses were long-lasting. The main side effects seen with this bispecific T-cell engager was cytokine release syndrome, which most of the time was grade 1 or 2 and easily manageable. For patients in the first-line setting, there was an update on the Checkmate 9LA study with 2 years of follow-up. And it appeared that Nivolumab plus Ipilimumab with limited chemo appeared to maintain with longer follow-up at 2 years, a continued overall survival advantage and continued progression-free survival advantage when compared to chemo alone. Also, there was a study done looking at patients who got chemoimmunotherapy-based regimens containing atezolizumab versus chemo alone, looking at those who got immune-related adverse events and their efficacy outcomes compared to those who did not. In patients both on chemoimmunotherapy and chemotherapy alone, those with low-grade, grade 1 or 2 immune-mediated adverse events had better overall survival than those patients who did not have immune-mediated adverse events, and they had better survival with low-grade immune-mediated adverse events when compared to those who had higher grade, grade 3 or above immune-mediated adverse events. The Crystallus phase 1 study looked at a population of patients who had progressed on osimertinib previously, who had EGFR exon 19 deletions or L858R point mutations. And I looked at the combination of Amivantamab with Lazertinib, which is a tyrosine kinase inhibitor. In this patient population, there was efficacy seen with this drug. However, the efficacy appeared to be much higher in a small subset of 10 patients who had high immunohistochemistry expression for EGFR and MET, suggesting that this could be a potential biomarker for this patient population. But further studies are still needed to determine the proper utility of this combination going forward. So in summary, there are exciting new options for patients with KRAS G12C mutations, for patients with EGFR exon 20 insertion mutations, for patients who are progressing on osimertinib with classical EGFR mutations. And there are some new immunotherapies emerging, particularly for patients with small cell lung cancer, in particular bispecific T-cell engagers targeting DLL3. Thank you for your attention.